Hi everyone. After listening to algorithms of bariatric surgery, the morbidities and mortalities, I think it's time we should just talk of something lighter, less complicated, less morbid. I'm going to talk on the role of non-surgical treatments in reduction of waist circumference and resistant fat. We all know what is obesity. It is by definition excess of fat storage rather than weight, and men with more than 25% and women with more than 30% of the total body fat are considered as obese, and WHO has already classified it as a disease, also called as obesity. These are the recent WHO 2012 figures where 12% of the world population is considered as obese, where Americans have highest levels of obesity, that is 26%, and Asians are the least, that is about 3%. Our parameters to assess obesity are BMI, we all know, weight in kg by height in meter square, waist circumference, waist to hip ratio, and skin bone thickness. This is how we do the body composition analysis to find out what is the fat percentage, what is the water percentage, and the total body mass. We must know what are the causes of obesity. The main three causes are diet, metabolism, and activity. And what contributes to diet is socio-cultural, biomedical, mental factors, and medication, while metabolism is governed by age, gender, genetics, hormones, skeletal muscle, and medication, while activity is mainly because of the socio-cultural effect, biomedical, again mental conditions, and medication. Is obesity a lifestyle disorder? Yes. Eating too much is a habit and a lifestyle problem. It's a result of inappropriate relationship of people with their environment. This is a disease you're not born with, but it's resulted with the risk factors like sedentary jobs, inactive lifestyle, wrong eating habits, lack of sleep, stress, alcohol, and smoking. We all know the impacts of obesity. We've been learning from yesterday. All the conditions, systemic conditions, the entire body is affected because of obesity, right from cardiology, skin, endocrinology, we're talking of diabetes, PCOD, then even GI reflux, fatty liver. In neurology, we are talking of carpal tunnel syndrome, dementia. Yesterday, I think we discussed about a lot of cancers predisposed because of obesity. Also rheumatology, orthopedic, urology, you name it, and each system is affected because of obesity. Now, what is abdominal obesity? It is also known as belly fat, or clinically as a central obesity, which is an excessive abdominal fat around the stomach and abdomen. There is a strong correlation between central obesity and cardiovascular diseases. The different criteria to assess the health risk are obviously abdominal obesity given as waist circumference, fasting HDL cholesterol, fasting triglycerides, blood pressure, and fasting blood glucose. This is the representation of cardiometabolic syndrome. Initially, it starts with the local metabolic abnormalities in adipose tissue, liver, skeletal muscle, pancreas, and nerve system, leading to systemic metabolic abnormalities with visceral obesity, insulin resistance, glucose intolerance, dyslipidemia, and hypertension, and again giving rise to systemic diseases. This is a representation of how a person is affected because of different genetic and environmental factors leading to metabolic syndrome and insulin resistance. Why is abdominal obesity so important? Because statistical correlation says that there is a definite relation between abdominal obesity and associated health risk. An obese man with a waist circumference of more than 40 inches is 5 times more likely to develop type 2 diabetes, 3 times more likely to develop cancer of the colon, and more than 2.5 times likely to develop high BP. An obese woman with waist circumference of more than 36 inches is almost 13 times likely to develop type 2 diabetes, 4 times to develop high BP, and 3 times more likely to develop a heart attack. So how do we treat obesity? The conventional modalities of treatment are, as we all know, lifestyle modification, which includes diet and exercise, cosmetic surgeries like liposuction, tummy tuck, and bariatric surgery, as Dr. Fobi was talking about. The conventional modalities of treatment include behavioral modification with caloric restriction, LEDs, that is low energy diets, and PLEDs, that is very low energy diets, are becoming very popular, along with physical activity, and the surgical modalities of treatment bariatric surgery. He's already talked about gastric sleeve and bands and balloons, liposuction, lipectomy, abdominoplasty. Okay, but then, there are people who say, okay, I don't want to do this. I don't want to do the bariatric surgery. I don't want to do this diet and exercise. And I've been there and done that. Still, what to do? My tummy is just growing. Okay, then what do I do? Okay, do we have something? Well, we didn't have anything about a few years ago. And now we have something which is non-surgical, safe, effective, and without any cut. And that is the non-surgical treatment, that is high-intensity focalized ultrasound. So we have 3 treatments which come under non-surgical obesity treatments. One is high-intensity focalized ultrasound, second is endermology, and third is physiotherapy. Now, who is the right candidate for this high-intensity focalized ultrasound treatments? There are some people who have tried all means of weight loss, have lost weight but not losing anymore. They have stubborn areas of fat or cellulite in otherwise non-obese individuals. Like some people fall in the normal range of BMI, but they have fat around their hips, thighs and abdomen. Then there are some who are unable to diet or exercise. So let's say because they have osteoarthritis or some back or knee problem, or they have diabetes. So they are not able to follow the strict lifestyle modification. Or, like in film stars, they want to have a perfect figure, but maybe an inch here and there they just want to lose. So we talk of what is high-intensity focalized ultrasound. The history goes back to 1930 when there was extensive use of ultrasound for medical therapies. And in 1956 it was suggested that we can use it for the treatment of cancers. Way back, that is in 1990, first time HIFU was being used for the treatment of benign prostatic hypertrophy. And at the same year, they started using HIFU for lipolysis. In 2004, treatment for uterine fibroids was approved by the FDA. This is how you can have a picture how this is HIFU is done. These waves are focused up to 1.5 centimeters below the skin to destroy the fat cells. These are focused therapeutic acoustic waves which do a selective lysis of adipocytes. Ultrasound waves generate a mechanical effect in the confined focal volume, causing fat cell membranes to rupture, and the mechanical effect ensures that only the adipose fat tissue is targeted and the surrounding tissue is not affected. What happens to the fat cell at the cellular level? The action one is there's a depolymerization of triglycerides and increase in the fluidity, followed by lipolysis or ejection of fatty acids from the adipocytes. This is with the wild stable cavitation phenomena by increasing the permeability of the adipocyte. And then there is a defibrosis by mechanical action of the connective tissue. The second action is fat is liberated in the interstitial tissue, which is then picked up by lymphatics. This is how lysis of fat cell looks like. This is a histopathological view of treated and untreated cells, and you can see the ultrasound beam which is going into the fat cells. And then there is a photograph of ruptured cell after ultrasonic treatment. The second treatment is endermology. The first treatment which is approved by FDA to allow temporary reduction of cellulite for reduced body measurements, increased circulation, relief of muscular pain and reduction of muscle spasms. It is a massage machine with 2 rollers and a gentle suction action. When rolled over, it just makes a fold, it stretches the connective tissue and results in the reduction of cellulite and body measurements. You can see the strands, the connective tissue strands, the brown fat cells underneath the skin. It has an effect on revitalization, oxygenation, and reduces bloating, and it dissolves fat by lipomobilization. Another third very effective and very popular method today is physiotherapy, more often used in European countries. This targets problem areas like, let's say, hips or thighs, with micro injections of some conventional or homeopathic medicines which consist of vitamins, minerals and amino acids. These medicinal bullets are delivered directly into the mesoderm that are highly specific to the condition being treated. These are the various types of solutions which have procaine, trental, sometimes serum, lidocaine and phosphatidylcholine. So all these, sometimes aminophyllin is used which go deep into the fatty tissues. The therapeutic uses of physiotherapy are to eliminate cellulite and to promote weight loss. It is very effective as an anti-aging of the skin and to sort of dissolve the localized fat deposits. These are a few new treatments which have not yet clinically substantiated its use. They are cryolipolysis, which is called as cool sculpting, which is deep cooling, which sort of destroys fat cells. There is something called as laser lipolysis and eye lipo. The treatment protocol is we normally take a history of the patient and then do a body composition analysis, BMI, then waist circumference, waist to hip ratio, and clinical examinations. The investigations done to rule out any liver pathologies. Then there is a personalized counseling done to understand which area a patient is interested in getting rid of the stubborn fat, and then the treatment is advised. This is a comparison between various treatments of fat loss, downward diet, exercise, liposuction like surgical treatment, which is more cosmetic, bariatric surgery, and non-surgical. Out of which in diet and exercise it is not a targeted loss of fat cells over a particular area. But in liposuction, yes, it is targeted. Again, in bariatric surgery, it is not a targeted fat loss, while in non-surgical, it is a targeted. Results in all the three, liposuction, bariatric surgery, and non-surgical, they are permanent, while diet and exercise, once you give it up, well, it comes back. Amongst the effect, yes, diet and exercise is gradual, liposuction is quick, bariatric surgery is again gradual, and non-surgical is also gradual. The risk, I think wherever there is surgery, risk is involved. In diet and exercise, there is no risk, and in non-surgical, there is no risk. And also, there is no hospitalization and there is no pain. These are some of the results of the patients we have done with non-surgical. Of course, this is not after one session, but it is after a series of sessions where the patient is, we've done fat loss treatments with EPU, then endomology, and also we've done a bit of tightening with radio frequency and lasers. You can see we have done on various areas of the body. To understand its effects on various body parts of different ethnicities, we did a multi-center study. It was a randomized, controlled, multi-center, multi-racial study, and we compared the effects of lipolysis and the body fat percentage. And we did this study on various races, that's Arabic, American, Canadians, Egyptians, French, Indian, Italians, Lebanese, Pakistanis, Syrians, Spanish, and Tunisians. It was observed that average reduction of waist circumference after one session was about 2.029 centimeters, and reduction in the total body fat percentage was 1.1375%. But the risk, whether the health risk was associated or not, was not seen in this. There is one very interesting topic I want to touch where are physicians slow to address the obesity problem? I wasn't sure whom I was addressing. I thought I was going to address the physicians and surgeons. So, because they are the ones who have an impact on obesity in general and obesity in community. So it is seen that about 90% of the doctors feel it's their responsibility for the patients, to lose weight. But 72% said that no one in their practice has been trained to deal with it. And 39% of the obese adults were ever told by a doctor, that they were obese. And of these, 90% were told to lose weight, but 1 in 3 said they weren't given any guidance on how to do it. So this is a sort of a clinical inertia we are talking about in all of us, the doctors who are generally seeing patients, the general practitioners. They're not seeing the patients for obesity, but they don't want to tell the patients. Why should a physician be concerned about the obesity? Is identify obesity as a disease in general population. Don't wait for obesity-related complications and morbidities. And care and concern will help boost confidence for the physician and develop a good relation. And very importantly, patient is more likely to remain with you for a longer time in the future. Fat doctors are less likely to help obese patients lose weight. Normal weight physicians were more likely to talk about weight loss with their obese patients, 13% versus 18%. So we have to inculcate all these habits ourselves when we're talking obesity. So this is just to practice what you preach. We doctors ourselves have no time to do all these things, but I think we should be doing physical activity, dietary modification. We're all too stressed with the fat of our own patients, so we should have stress management and maintain healthy BMI. This is what is my message to all of us who are into active clinical practice of obesity, that we should practice what we preach. Thank you. I would welcome Ms. Handrui Zhang from University of Pennsylvania School of Medicine. She's obtained her MD and MSc in Chinese Medicine from Beijing University of Chinese Medicine and PhD in Pharmacology from University of Missouri. And she is an author of 25 papers in obesity. Impressive.